Welcome to Applying the Fundamentals of Insulin Physiology to Build a Better Insulin. Highlights from ACE and ADA. This program was originally presented as satellite symposia held at the American Association of Clinical Endocrinologists and the American Diabetes Association's 2015 annual meetings. We thank you in advance for participating in this important CME activity.
My goal, I think, this evening is to try and outline some principles of normal insulin physiology. And those will focus on a variety of things, but the hope is that at the end of this talk you'll have a fairly clear idea of what happens in a normal individual. Specifically, the things that I would like to do are shown in this slide. So there's 5. Part of what I will do today is talk about some of the data that we've accomplished over the years using the dog model. And I would point out that the dog model is actually very useful because you can do well-controlled physiologic experiments that you simply can't do in a rodent because it's too small, and you can't do in the human because they're too invasive. And this is helped by the fact that data in the dog has translated very well to the human. For instance, there's 95% gene homology. So it's a good model to use, both because you can do unique experiments and because they are likely to translate to the human. And I'll show you some of that data today. Okay, first point. So what are the levels? If you just take all the data we've accumulated over the years and you ask what are the levels of insulin in the various sites, what you can see is that the arterial insulin level would be about 7. The portal vein insulin level is approximately 3-fold higher than that, and the hepatic vein level would be just over 8. So here's the way you could calculate the concentration in the blood entering the liver. 30% of the blood flow is arterial, so you multiply 0.3 times 7, the arterial insulin level, to get the contribution coming in from the artery. And then you do the same with the portal vein, which is 70% of the flow. The portal vein level was 21, so that equals 14.7. If you add those two together, that's the concentration of insulin that enters the liver where the flows become confluent. Then, of course, if you look at what's coming out of the liver, it's about 8. So you can calculate the fractional extraction of insulin by the liver, the amount of the insulin that it sees that it actually destroys. And that is shown here. The concentration of insulin going in minus the concentration coming out divided by the concentration going in, and here's the math. And you can see that in this example, it's about 50%. And these numbers are almost identical in the human. So under most circumstances, the liver destroys about 50% of the insulin that it sees. Now, that number will not change acutely, but it can change chronically. For instance, if you overfeed an animal and they become obese, or in obese humans, then the fractional extraction begins to drop, and is part of the explanation for why the level of insulin in arterial blood tends to go up under circumstances like that. Okay, let's first then talk about, with a reasonably high increase in insulin, how quickly do the system respond, and how do muscle, fat, and liver compare? So you can see data here from an experiment in which there was a 30-minute control period, then a 4-hour test period. We're going to give somatostatin, inhibit the endocrine pancreas, put glucagon back basally, so we can isolate the changes that we're going to see here to insulin. We're going to clamp the glucose to stop it being a variable. And there were 2 limbs to the study. A control limb, where we just kept insulin basal throughout, and you can see the arterial insulin in this case was about 5. Portal vein would have been about 15. And another group in which we elevated insulin in the portal vein. So we infused it at about 8-fold the basal rate. And you can see the arterial insulin level was about 44. The portal vein would have been 3 times higher than that. Then what we did was to take samples and stop experiments at either 0, a half an hour, 1 hour, 2 hours, or 4 hours. And we did a whole molecular analysis to try and correlate molecular changes with the physiologic changes. I'm not going to go into that data. I'm just going to show you some of the physiology from the elevated insulin group. So what you see here, the bar in white is the control period. The bars in blue are the subsequent data at a half hour, 1 hour, 2 hours, and 4 hours. So you can see at the top, we did in fact maintain euglycemia. If you look at the top on the right, you can see net hepatic glucose balance. So we're using the AV difference technique to assess what the liver is doing. And the first thing that I want you to take away is the inhibition of net hepatic glucose output is rapid. By 30 minutes, the liver is almost off. And by an hour, it is off. And then it goes into slight uptake. The AV difference technique allows you to not only see the liver as a producing organ of glucose, but as a consumer. Now, if you ask the question, is this due to a change in gluconeogenesis or glycogenolysis? You can see, if you look at the lower left, that it's basically a glycogenolytic response. There's a very rapid inhibition of glycogen breakdown. It's almost complete at 1 hour, and then you actually begin to synthesize a little bit of glycogen. Gluconeogenesis, shown on the bottom, on the right, doesn't change. So the things I want you to take away from this are the speed of the response of the liver. It's very quick. And I want you to remember that that quick response is due to an inhibition of glycogen breakdown. Another thing that happens, same experiment, if you look at lactate balance across the liver. In the control period, the liver is taking up lactate. The Cori cycle is functioning. Once it sees the insulin, however, that reverses, and the liver begins to export lactate. You can see that that's also occurring at an hour. It stops at 2 hours, and by 4 hours, you're right back to where you started. If you calculate glycolysis, which is shown on the bottom, you can see what happens is there is an increase in glycolysis that occurs right away. So insulin is doing two things. It's stopping glycogen from breaking down, but it's enhancing the flux of the glycogen that is still being broken down to pyruvate, to lactate, and out. So again, blocking the release of glucose from the liver. So there are two mechanisms by which insulin has this quick effect. One on glycogen metabolism and one on glycolysis. If you look at the fat response, you can see that the free fatty acids drop quickly and dramatically, again giving you the impression that fat metabolism, the adipocyte responds equally sensitively to insulin as does the hepatocyte. If you look down at the bottom, you can see glucose utilization, and a rise in glucose utilization under euglycemic conditions really reflects glucose uptake by muscle. Teeny little bit, as you saw, by liver, but the majority of that is in fact muscle. And there's another lesson. The effect of insulin on muscle glucose uptake takes hours to come to a steady state. It starts quickly, but it grows progressively over time. So if we put this data together and try and draw a dose-response curve, and we look at net hepatic glucose output relative to the level of insulin that exists within the liver, you see data from the dog on the top and data from man on the bottom. And I just want to make the point that if you look at the word basal, and look first at the top, you can see that under basal conditions, you're in about the middle of the dose-response curve. And if you keep the number 3 in mind, it comes in handy, because if you drop insulin to 0, glucose production will triple. If, on the other hand, you increase the insulin level by 3-fold, glucose production will completely stop. The dynamic range of insulin between 0 and 3-fold its basal secretion rate, which is about 250 microunits per ml, can set the glucose production rate anywhere from nothing to 8. There's a tremendous fidelity in the translation of a signal. It has a lot of power. And if you look at the bottom, and these are data taken from the literature, you can see that exactly the same relationship exists in man. So the liver is very sensitive in its response to insulin. Here's a comparison of the sensitivity of the liver and muscle. So shown in red, and that's a log scale, so it's target cell concentration. So this is normalized to get the level of insulin at the two tissues equal. And you can see that as soon as you start increasing insulin, the liver begins to shut down its glucose production. On the other hand, nothing much happens with glucose utilization. It takes a while, and you have to get the insulin level up much higher before glucose utilization will increase. So there are two reasons why you would predict that the liver would be much more sensitively controlled by insulin than is the periphery in the terms of muscle, so glucose utilization. One is because the liver sees much more insulin than muscle does, and the other is because the liver is much more sensitive to insulin than muscle. So if you now look at some data where we did experiments, and what we did was to infuse insulin at fairly low rates into the portal vein, or at the same rates into a peripheral vein. So looking at the route of insulin delivery. And the yellow dots, the yellow line, represent what happens if you infuse insulin portally. Now, as you read the decrease in the bottom, so the 0 is no decrease, 1 is a decrease of about 30%, 2 is obviously 60%, and 3 is getting up to 90%. And the bottom line, the message here is that when you deliver insulin intraportally, you can control liver glucose production without affecting glucose utilization. In other words, the line is flat at the origin. There's no slope to that line. If you do the same thing delivering it peripherally, which of course is what you have to do when you treat patients with insulin therapeutically, sub-Q, you see that you cannot change glucose production. You can't inhibit it without also activating glucose utilization. And that's important. What happens then if you say, how important then is the portal insulin delivery rate? What happens if you suddenly were to switch that from portal delivery to peripheral delivery? And so what you can see here on the top is the arterial insulin level, on the bottom is the sinusoidal. The yellow line is when we did not make the switch. In the orange data, at 0 minutes, we simply took the infusion line out of the portal vein and put it into a leg vein. And what that does, of course, is raise the arterial insulin level at the expense of the insulin level at the liver. Now, based on what I've told you, what would you predict is going to happen here? That change in arterial insulin is small. You really shouldn't do much to peripheral glucose utilization. On the other hand, although the change is small at the liver, given what I've told you, it's very sensitive. You might predict the liver is going to see an insulin deficiency and it's going to overproduce glucose and you're going to end up with a hyperglycemia. And that's exactly what happens. So if you look at the middle panel, you can see glucose production in the orange group. Once you make that switch, the liver sees it, begins to produce more glucose. That creates hyperglycemia, shown in the top panel in orange. That tends to then feed back and start to shut glucose production back down. Notice glucose utilization, as predicted, has not changed. The control group, we actually infused glucose to match the glucose levels, and that causes the drift down in the endogenous glucose production. So clearly, the fact that insulin is delivered portally is not just a nice way to get insulin into the body. It has absolutely important metabolic consequences. How then does insulin bring about its effects? And there are many ways. You can affect it directly, so insulin receptors on the liver working through the canonical insulin signaling system, phospho-AKT. You could perhaps hit muscle, change protein synthesis, protein degradation, change amino acid flow. Amino acids can fuel gluconeogenesis. You can hit the pancreas. It turns out that the alpha cell has insulin receptors. You can inhibit glucagon secretion, which would inhibit glucose production. You can affect fat. Insulin will inhibit lipolysis, decreasing glycerol and decreasing fatty acids, which are energy to the liver. And there's a lot of data emerging that the brain is insulin sensitive, and that might feed back and affect the liver. So which of these are important? Well, I can tell you, before we talk about the alpha cell, that muscle and the amino acid effect is not important. The response time is too slow, and the dose-response characteristics are such that that just is not a player in regulating acutely glucose production. The alpha cell, however, has more of a chance, and what you can see here is experiments in which insulin was infused at 0.3, 0.6, or 1.2 millunits per kg per minute into a normal animal. And what that does is raise the insulin level. And there are two observations here. What you can see in the yellow is that C-peptide, which is an index of endogenous insulin secretion, shuts down in a dose-response fashion. Insulin inhibits its own secretion. Secondly, down on the bottom in green, you can see that insulin also inhibits glucagon secretion. So for people doing clamps, I think it's wise, if you can't control glucagon, to at least measure it, because I can tell you that a change in glucagon of that magnitude would definitely have an impact on the liver. What happens then to direct input? Can we prove that if all that happens is the liver sees an increase in insulin, that it will respond? So you cut out all those other mechanisms. And what we have here are two sets of data. Shown on the left are control data in yellow. Shown on the right are data in which we selectively, and we can do this in the dog by having catheters in various places, we selectively raise portal insulin. Arterial insulin, which you can see there, remained clamped. Now, that means that the brain, the muscle, fat don't see a rise in insulin. And we've clamped the glucagon, as you can see. So this is really testing whether portal insulin can affect glucose production by the liver. And you can see, looking at the left on the bottom, the orange, there is a quick and substantial response to that relatively small change in insulin selectively at the liver. In fact, we had to infuse glucose to clamp the glucose level. And you can see it in contrast to controls. And if you look to the right, you can see that the small drift down in net hepatic glucose output in the controls was a function of a small drop in glycogenolysis, no change in gluconeogenesis. The effect, the direct effect of that insulin on the liver, once again, as I showed you earlier, was glycogen, not gluconeogenesis. What about if you do the reverse experiment? In this case, keep the portal vein insulin clamped, but raise the arterial level. Allow the brain and the fat and the muscle to see a change. Again, glucagon is clamped. And what you can see, interestingly, again, lower left, is that they can also reduce glucose production. It's a little more sluggish. It takes about 30 minutes longer. It's almost as big. It's a little harder to see what causes it, and I'll explain why that is in a moment. So the glucagon was clamped. We've ruled out muscle. That means the likely candidates for this suppression are either the fat cell or the brain. So we did an experiment to see whether it could be an inhibition of lipolysis. And what you can see on the left in yellow is that we recreated that condition. So you have a clamped portal vein level of insulin and a rise in the artery. And that was almost identical to the data on the right in orange. Except in one case, we allowed fatty acids to fall, and in the other case, we infused intralipid and heparin and prevented that. And what you can see in the lower left is that indeed, when we redid the experiment that I just showed you, we got the same effect, a delay of 30 minutes and then a fall. But when we stopped the fatty acids from falling, we prevented that. And you can see, looking at the lower right, why that is. So this is the release of lactate, which reflects glycolysis. When fatty acids were inhibited and not there, the liver used glucose as its fuel. And so you got that change. When the fats were there, that change in the flux down the glycolytic pathway just didn't happen. And this relates to the role of the brain. And this is a controversial area. If you read Diabetes or a number of other journals, you'll see quite frequently papers that are attempting to discern whether in fact the human brain is insulin sensitive and whether that can have an effect on glucose homeostasis. So I would show you these data in explanation of that particular outcome. So what we had done, what has been found in the rodent is that the brain of the rodent detects insulin in the circulation, even fairly low levels, that you start the canonical insulin signaling pathway, increasing phospho-AKT. That changes the potassium channel. You get a signal down to the liver, which results in an increase in phosphorylated stat there, just a marker of the brain talking to the liver. And you inhibit the gluconeogenic enzymes and you genetically, and you shut down glucose production. So that's the dogma in the rodent. We did study to try and see whether the dog brain would do the same thing. And sure enough, if we increase the insulin level in the blood, and we then go and take the hypothalamus and look for whether it activated, it does. So like the rodent, the dog brain activates in response to a signal of insulin. It also signals the liver, so phospho-AKT goes up. It also can repress gluconeogenic gene transcription and actually augment glucokinase gene transcription. So in answer to the question, does the brain see the circulating insulin level? The answer is yes, and my guess is that's also true in the human. But then the question is, does that make any difference metabolically? Remember that there's all those other mechanisms by which insulin can affect the liver. And so we did the following experiment, and there was a 30-minute control period, an hour period during which we were either going to infuse an inhibitor of insulin action into the third ventricle, which makes its way into the brain. And we showed that it only took about an hour to do that, or we weren't. So we're going to challenge the animal with insulin with the brain on or off. And we're going to ask if we can confirm the signaling, does that make a difference or not? So here you see the insulin levels. On the top, the artery. On the bottom, the hepatic sinusoidal. You can see that they're identical whether we turn the brain off or not. And you can also see that in each case, there's a rise of about six-fold, but it's 3 times bigger at the liver than it is at the periphery. Okay, shown on the top on the left is the hepatic phospho-AKT. So this is an index of insulin signaling at the liver, and you can see that it's the same whether the brain is involved or not, the orange and the yellow. Because remember, there was hyperinsulinemia directly at the liver, and we know that that hits the liver from the data I showed you. If you look just across on the right, you can see that hypothalamic phospho-AKT was activated. So this proves that that insulin gets from the circulation into the brain and turns it on. But the orange shows you that we can, by giving that LY, block that. The middle panel shows you that the brain talks to the liver because the phosphostat went up. And when we inhibited brain insulin action, in the orange, you can see that that was eliminated too. Now the more relevant values are those on the bottom. You can see that the effect of insulin without the brain there, so the orange, was completely able to inhibit PEP-CK, a gluconeogenic gene expression. Adding the brain back in, the yellow, did nothing. Likewise, if you look at the increase in glucokinase, you can see that in the absence of the brain input, the orange, there was a robust activation. Putting it back made no difference. The yellow and the orange are not different. So this says that the liver is primarily listening to the direct amount of insulin that it sees. The input from the brain is there, but it's not going to accomplish much unless you become deficient in the direct signal. That response of insulin to shut itself down, is it driven by the brain? No. We got exactly the same inhibition of C-peptide, i.e. insulin secretion, whether the brain was in play or not. What about the fall in glucagon? Likewise, does not depend on input from the brain. This is a direct effect of insulin on the alpha cell. What about fatty acids and lipolysis? You can see either looking at glycerol or NEFA. Again, not dependent on the brain. This is a direct effect of insulin on the adipocyte. So, in summary, the liver normally sees about 2.5 times as much insulin as all other tissues in the body, and that's true for the dog and it's true for man. The data from man were derived many years ago when they were able to get portal blood by putting a catheter into an umbilical vein and going through. Fat and liver are very sensitive to insulin, while muscle is much less so. Insulin has a powerful direct effect on the liver. At the same time, its indirect effect on the alpha cell and adipocyte can impact the hepatocyte. The brain does respond to circulating insulin, and as a result signals the liver, but in the presence of insulin's other effects, this has little acute impact. But it does explain data in the literature where they knock out the insulin receptor on the liver, or they knock out a downstream signaling molecule and still get a repression of glucose production by insulin, because there are these other ways to do it. And if you take nothing else away from this talk, this is such an important function that insulin has that it can do it in a variety of ways. So what do I think the importance of brain insulin is? It's probably more about setting the tone upon which the acute impact of the hormone can work. And that is the area that we're currently studying. Thank you for your attention.
My name is Sundar Madalia, and I'm a staff physician at the Veterans Hospital in San Diego and a clinical professor of medicine at the University of California in San Diego. I'm going to be presenting on endogenous versus exogenous insulin, and specifically looking at the hepatic peripheral balance. First, when I was doing this presentation, I just looked into the literature and I found that insulin is actually evolutionarily a very ancient hormone, and insulin-like peptide genes have actually been found in invertebrates, including insects, mollusks, and nematodes. And this clearly establishes that insulin is very ancient. But the big difference is that in invertebrates, the insulin-like peptides function predominantly as growth factors to promote tissue growth and development. On the other hand, in vertebrates, this mitogenic growth function has been taken over by IGF-1 and 2, and insulin has now become predominantly a metabolic regulatory hormone. And insulin, as we all know, acts through its insulin receptor, and then after binding to the receptor, we get the metabolic pathway through PI3 kinase, AKT, and we get glucose uptake, gluconeogenesis, glycogen synthesis in the various tissues. The other pathway, the mitogenic and the growth pathway, results through the RAS pathway and gives us gene transcription and cell growth and differentiation. Insulin also, incidentally, has effects on the vascular endothelium and can cause both vascular constriction and vascular relaxation. But we will be focusing now on glucose uptake, gluconeogenesis, and glycogen synthesis, that is, the metabolic effects of insulin in the liver and skeletal muscle and adipose tissue, which represent the periphery. So insulin's skeletal muscle and adipose tissue are called the periphery because insulin is first secreted by the pancreas into the portal system and goes centrally first to the liver. So we have the liver and the periphery. So the effects on the hepatic versus periphery, the question that first comes to mind is, does it really matter clinically? Is it really relevant? For that, we first need to look at levels of insulin in the systemic circulation and the portal circulation. If you look at insulin concentrations in the hepatic artery and the hepatic vein, they're about 15 microunits per ml, whereas if you look at the portal circulation, the insulin levels are almost double, about 30 microunits per ml. When we give a glucose load, there's a sharp increase in insulin levels in the hepatic artery and vein to about 45 to 50 microunits per ml. On the other hand, in the portal circulation, insulin levels are about 2.5 to 3 times as high at about 150 microunits per ml. So clearly, in the human in the natural state, insulin levels are 2.5 to 3 times as higher in the portal circulation than in the systemic circulation. The question arises, can we mimic this endogenous insulin delivery by our current delivery systems? I think the first study that really demonstrated that we could do this was the VA cooperative insulin pump study. This was the implantable insulin pump study versus multiple dose insulin for patients with type 2 diabetes and was published nearly 20 years ago in JAMA in 1996. This depicts the insulin intraperitoneal pump, and it was a mini-med pump about the size of a puck shown there on the right with a long pigtail catheter which was inserted into the peritoneal cavity. On the left is the controller which could be placed on top and used to control insulin doses. This slide depicts the surgical procedure. To orient you, on the left side is the head end of the patient, and to the right, as you can see, there is the umbilicus, and the surgeon is placing the puck-shaped metallic insulin pump into the abdomen just under the subcutaneous tissue, and the catheter will free flow into the peritoneal cavity. What were the differences in the two groups? First, looking at glycemic control as measured by hemoglobin A1C, started at about 8.8% and came down to around 7.5%, the same in both groups. So there was no difference in glycemic control whether you gave insulin intraperitoneally or through multiple daily injections subcutaneously. What was different was glycemic variability as measured by the standard deviation of the blood glucose in milligrams per deciliter. With intraperitoneal insulin, it was the standard deviation was about 40 milligrams per deciliter, whereas with subcutaneous multiple dose injections, it was about 50 milligrams per deciliter, and significantly higher glucose variability for the same hemoglobin A1C. What was also different were rates of hypoglycemia. On the left, mild hypoglycemia is seen as events per patient per year, and both definite and suspected events were about a third lower with intraperitoneal insulin versus multiple daily injection subcutaneous insulin. On the right, severe hypoglycemia defined as the assistance of another person. Both definite events and suspected events were much lower, almost 3 to 7-fold lower with intraperitoneal insulin versus subcutaneous insulin. Also different was the weight between the two groups. And the weight change in the people who got the subcutaneous multiple dose injections, they gained about nearly 4 kilograms, whereas the people on intraperitoneal insulin did not gain any weight at all. So clearly, for the same hemoglobin A1C with intraperitoneal insulin, there was less glycemic variability, less hypoglycemia, and less weight gain. In this study also, they did a small sub-study in which patients, they looked at the acute effects of intraperitoneal versus subcutaneous insulin on glucose homeostasis. So each patient got 0.15 units per kg body weight on 2 separate days, either through the intraperitoneal device or these people got it through subcutaneous injection. And on the top left, you can see insulin levels when it is given through the intraperitoneal route peaks at about 1500 picomolar, almost 5 times as much as what you get through the subcutaneous delivery. In addition, after 120 minutes, the insulin levels when given intraperitoneally, they are much lower than you would get for the subcutaneous delivery. And this has implications for few hypoglycemic events. With their high insulin levels, you get more hypoglycemia. If you look on the top right, this is glucose utilization and the GDR. So immediately after the intraperitoneal insulin, the GDR peaks at about 4 milligrams per kg body weight per minute compared to about 2.5. So the prandial insulin, when given intraperitoneally, is doing its job of pushing the glucose into muscle tissue, which it is supposed to do. What happens to hepatic glucose production? What we see here is that with both intraperitoneal and subcutaneous insulin, there is a suppression of hepatic glucose production till about 120 minutes, and then after that, with intraperitoneal insulin, there's a recovery of hepatic glucose production. It tends to flatten out, whereas with the subcutaneous group, there is a further decline in hepatic glucose production. This will translate into, if there is less hepatic glucose production, there are more chances of hypoglycemia in the period after a meal, 3 hours after a meal. Free fatty acids were also measured, and what is seen is that both with intraperitoneal and subcutaneous insulin, there is a suppression of free fatty acids, which is what happens when insulin comes on board. But then after 2